Welcome to the webinar, Boundary Issues in Communicating with Patients and Their Families. I'm Barbara Lewis. Thank you for joining us. This webinar will last about 30 minutes, and if you have any questions, you can type them in the Q&A box or the chat. And if we don't get a chance to answer your questions during the webinar, we'll respond afterwards. But before we get started, let me talk briefly about .com. .com is a proven online interactive healthcare communication skills learning system, and it is media rich. It's an interactive platform for acquisition of knowledge, skills, and attitudes. We have module authors who are leading faculty and 42 multi-rich interactive online modules, over 400 videos, realistic, unscripted videos, and annotated interactive videos as well. On the back end, we have a huge learning management system, which you might want to check out. The great thing about .com is that you can access it anywhere, anytime. We have 10 journal articles that have been written about using modules and the value of .com. Over 300 institutions have used .com and over 100,000 subscribers. We were in at least 20 countries, and we've been translated into 3 languages, including German, Japanese, and Portuguese. There are 10 journal articles that talk about the .com modules. And here's a few of them here. A sister platform of .com is professional formation modules, which you can see here. We have also 2 faculty modules, one on faculty development and one on remediation. So without any further ado, let me introduce our presenters today. Joining us are 2 authors of the .com module on boundary issues. Dr. Olani Romanis-Sakaris is the Director of Pediatric Hemoglobinopathy Specialty Center at Staten Island University Hospital, and Dr. Kanta Valamuri is Associate Professor at Baylor College of Medicine and the VA Medical Center. The presenters have updated the .com module on developing boundary issues for learners. Dr. Valamuri?
Thank you so much, Barbara. It's a pleasure to be here and talk about boundary issues. There's a few key principles that we're going to cover. As you all may know, whatever field you're in, whatever your degree of experience, boundaries and the interactions when boundaries are challenged are problematic. And it's unclear sometimes what actions one should take and how one should behave. And clinicians are regularly confronted with these. It's not something that's a rarity, but something that we have to try and decipher often. And it's a best practice or ways to handle these would be to know the communication skills. And that's something that we're going to try and cover today, as well as is there in that extensive module that Barbara talked about. But basically what we're going to cover is that communication when boundary issues arise should be based on ethical and professional standards and should at the same time convey respect for the patient's feelings so you don't leave them feeling uncared for. And they are complex situations. So our goals for this module, as well as this session, are to describe some of these situations that clinicians commonly encounter, reflect on what appropriate limits should be for clinicians like yourself, describe strategies for responding to some of the situations. So we'll give you some tools to help if you're in those situations yourself, and then demonstrate how to use the communication strategies in these situations. So to start out with, I think it's very important to remember 5 principles. So if you have these principles in the back of your mind when you're in the situation, you may want to reflect on those principles as you're dealing with the situation. So the first is to operationalize altruism. Second is to try and understand where the patient's coming from, what the patient's motives and needs are. Have some self-reflection, understand your own motives and needs. Remember, there is an inherent power differential, and then trying to build safety and trust. And I'm going to go into detail of each of these a little bit. So the first key principle to remember is to operationalize altruism. Altruism is the leading principle that we are asked to follow in healthcare. So you want to consider how your actions and your words will benefit the patient or not harm the patient. So even words make a difference. So when we have that principle of do no harm, remember how you respond to things that your patients say could also be harmful. So always think about doing things and acting that would benefit the patient while staying within the limits. So some of the questions you can ask yourself when you're in these situations are, is this action in the best interest of the patient? Is this going to not only help the patient, but ensure that we have a successful ongoing professional relationship in the long term? And is this action that I'm doing something that's just going to help now, but may harm things in the longer term? Or is it something that's going to encourage thriving in the longer term? So you want to see that when you're taking an action, you are thinking about the patient and what the patient would be benefited by and what their needs and interests are over your own personal needs. That is what the principle of altruism suggests. A second principle is to understand what the patient's motives and needs are. So where is the patient coming from when they're doing that action that may put you in an uncomfortable situation or a boundary challenging situation? So for example, gift giving. So what does the patient mean when they're giving the gift? Is there an ulterior motive? Are they trying to curry favor, or is it just something that's harmless that they do for other people as well? So what does it mean to the patient? You want to show respect and interest in what the patient is saying and show that you do have an interest in their well-being. And so even if you decide that accepting that gift is not in the best interest of the professional relationship, you still respect them as a person. So it's important to show that. And avoid any hunches and assumptions. Just ask the patient. So you don't want to think, oh, I think this patient is giving me a gift because of XYZ. Just be direct and have direct communications, and that's always good in the long run. Try and understand what the underlying meaning of the gesture is. And having some cultural competencies in this may also be important, because things like gift giving may be different in different cultures, and the underlying meaning may be different for the patient than for you. A third principle is to, like I said, do some self-reflection. Understand your own motives and needs when you're in these situations. So some of the things you can think about is, am I identifying with this particular patient, and is that guiding what I'm doing or how I'm behaving in this situation? Or do I really dislike this patient and that's impacting how I'm behaving in this situation? Would I do the same with other patients as I'm doing with this patient? Sometimes a patient can remind you of a family member or a friend in a similar situation, and that may cloud how you behave in that situation. So try and understand your own motives, decide whether you have any conflicts of interest with this patient that may be playing a role in your action. And do pay attention to your own emotional reactions. Some of these boundary challenges are very difficult and can impact how we reflect, and it may play a long-term impact on us as well. Now, remember also that in physician-provider relationships, there is a power differential. So patients do perceive care providers as being powerful. They know everything and should listen to whatever the provider is saying. And that can become an issue when there are boundary challenges. There are especially when people are ill or vulnerable, they look towards the clinician as this parental figure, as somebody who's going to take care of them and fix things. And so remember that power differential is playing a role and could easily be taken advantage of if it's not a principle that we think about. Don't discount any attempts to cope that may lead to invitations, gift giving. That may be their way of coping, but this may not be appropriate in the situation, but just be aware of that. And lastly, the principle is to always keep safety and trust. So take actions that make the patient feel safe and trust you, and not cross the boundary that will make them not feel safe anymore. So you need to start with a firm boundary. It's always easier to set a firm boundary and then relax a bit depending on the situation, rather than, going ahead with a flexible boundary and then having to set limits after the fact. So if you're going to adjust the boundary, however, you need to have a thoughtful conversation on why this boundary is being relaxed, what it is for, so that then there's not pushing of the boundaries further. So for example, if a provider decides to give a patient their cell phone number and it's only for one particular situation or a particular situation to prevent hospitalization or a call, or you call me if this happens, but setting that another boundary when you're relaxing one boundary of, for example, giving the patient your cell phone number. So here are those are the principles that you'll think about in the background. And here are some things you can do when you're in the situation in terms of communications, how you can say things to maintain those boundaries with your patient. So here are some strategies for communication. First strategy is to appeal to medical ethics or professional standards. There are a lot of ethical guidelines, and if you look at the module, actually, we have a list of references of a lot of different professional boundaries, standards, and ethical standards. So you have to you can tell your patient that what you do is based on professional guidelines from groups that you're accountable to, and let them know that you honor those boundaries. So those are some words you can use when you come up with these challenges. For example, I'm sorry, but it's against the Board of Registration guidelines, or it's against my Texas Medical Board regulations for me to write a prescription for somebody who's not my patient. So Dr. Ramona Sirakis is going to talk about some specific situations, but this comes up often when we're asked to, can you just write a prescription for me from our friends? So you can use professional standards and guidelines to set those boundaries. Another thing you can use for communication when you're in these situations is to appeal to general principles. So you can say that these actions that you're taking are based on general principles. It's not specific towards that specific patient, and that if there was any other patient in the same situation, you would use the same principles. And so help them see that it's a general principle. So some of the words you can use there is, I have a rule, or I have a rule that I do this with all my patients, or I have a rule that I don't give out my cell phone number to my patients. You can also use words like my practice, or my view, or my belief is XYZ, and therefore I do this towards you. This is why I'm making this decision, because this is my principle, this is my belief, and it's not unique for this patient. It's something that I do for all my patients. The other thing you can do is to try and reiterate the nature of the relationship. So you want to remind the patient that this is a professional relationship. This is not a friendship relationship, even though your friend could be your patient at times, but the relationship that the patient is there for is a professional relationship. So if you can say things like, sometimes it can be complicated for a caregiver to interact with a patient outside of the medical setting. And it may cloud my judgment. And this could come up if a patient, for example, invites you for their, birthday party or something like that. So you can say that. You can say that, you have this relationship. I'm a medical student, and so I cannot take this, but I will defer. So establishing where you are, what the relationship is, can help in those communications as well. You should also give yourself time to consider what the challenge is. So you don't have to make a decision right away. So some of the words you can use is trying to get yourself time. So you can reassure your patient that the relationship is important. Reassure them that you want the patient to feel cared for, and then ask for time to reflect on it. So you can say things like, oh, I'll need to think about it, or I'm going to talk to my preceptor, or let me think about it. I'm going to consult some of my colleagues. And that brings me to the last communication tip that you can use, is to call on your colleagues and trusted mentors. The more that we do this, the more challenges and boundary issues we come across. So there may be colleagues who've seen something that you haven't. So gain perspective and ideas by seeking advice from others. Do self-reflect and bring your issues and emotions to light, and then consult them on the challenge. So you can ask your colleagues things like, have you encountered anything like this? What have you done? What would you do if you were in my shoes? If you've had an experience like this in hindsight, would you have done it the same? Or how do you think I should have handled that experience? How should I have prevented this issue from arising? So talking to your colleagues it's going to be a good skill as well. And recognize that some teachers will have different experiences and views. So what your colleagues tell you may not be necessarily what you're going to implement, but having their input definitely will help you make that decision. And now I'm going to turn it over to Dr. Romana Sirakis to talk you through some specific situations that come up.
Thank you so much. And good morning and good afternoon to everybody here. So what I wanted to do was present a few just case examples to get you thinking about professional boundaries and how you might react if you were to encounter similar scenarios. And what we know is that not every scenario is really so clear-cut, and the answers are not always universal. So we can just go through some specific scenarios on these topics. We're going to look at self-disclosure, gift giving, and that's from the patient to the clinician, financial assistance from the clinician to the patient, social invitations from patients, clinician-patient touch, boundaries in the digital age. That's a new one that's really emerging and continues to emerge. And then treating VIPs, friends, and family members. So we'll start with self-disclosure. Okay, so you can use or express something from your own life to help a patient sometimes. And this may be a way to share struggles and allow for building rapport or benefiting the patient. So I can give you some examples that you may experience in your day-to-day life. So as a pediatrician, I often see patients or parents struggling with multiple children, or they may have children with a certain disability and struggle with that. So if I personally have experience similar to that, multiple children or a child with similar disabilities, I may be able to express that or disclose that to the patient's family, and that will make decrease the stress of the visit. For example, if I had a child who had autism and I see a parent walking into the room, they're struggling with a child who may not be able to comply with the behavior, may not be able to tolerate the waiting room, may be melting down, and they're visibly stressed by the whole situation. I may say to them, I understand what you're going through. I too experience similar things, and I have faced similar challenges. And maybe take a breath and we can get started. It may strengthen our relationship for them to know that I truly understand where they're coming from, and I'm not disregarding their struggles. And this may decrease the stress for the parent and allow us to build a better rapport. So another example may be no, not yet. I'm sorry. Another example may be a patient looking to try and lose weight for health reasons. Now, if you've gone through similar things or have had similar struggles, you may present to them, I too had difficulty, or I too had to go down this path. And there are certain things that worked for me that may be helpful to you. And I think that's also helpful for you to share that you practice what you preach and that you understand their struggles. And it may be a different road for each of us, but it's something that can help them. And then my third example here is very different. So this is all very different from maybe you're newly engaged and you have a new engagement ring and a patient comments to you, wow, that's a beautiful ring. And you spend the next 10 minutes talking about your fiance and your beautiful wedding that you're going to have. And you can't believe how he surprised you. And it's just wonderful. None of that really benefits the patient, and it's not really useful in that scenario. So you see, these are some different examples of how self-disclosure may help a patient and help your relationship, as well as one that may not really add to the scenario. Next slide, please. Okay, so self-disclosure can contribute to a healthy partnership, and consider if the disclosure will benefit the patient. Some of the advantages that we mentioned here are it can build rapport, and it can help the patient actually adopt better health habits. Diet and exercise is one example. If they know that you experience similar things and work together and a trusted relationship there. Next slide, please. The next case scenario I wanted to discuss was gift giving, and this is from the patient to the clinician. So let's consider a few scenarios here. It's relatively commonplace that maybe during the holidays or for a thank you, a patient may send cookies, they may send lunch, they may send chocolates, but now escalate this. They may send flowers, they may send a handmade gift, they may send candles, jewelry, maybe a luxury bag. So there's clearly a continuum here in terms of the monetary value, as well as the potential impact on the patient by giving this gift. So each organization obviously will have specific rules and regulations to abide by in terms of gifts. Next slide, please. And so it's important to consider certain things when you're considering whether to accept a gift or how to approach this. So I would say that you don't want to accept gifts unless you really examine the purpose and potential effect that the acceptance is in the best interest of the relationship. So number one, do you feel that the family is trying to buy better care, or that they're trying to give you a gift to change their care? On the other side of things, if I reject this gift, will it seem rude and appear to the patient as a rejection? So a family might say, I want to give you money, and indicate that it would be very rude if you didn't accept some kind of token of their appreciation for your care. And one way you may turn this around is you may say, I can't accept a monetary gift. I really appreciate it, but it would be a great benefit if you donated that money to a certain place, or to the hospital, or to a charity. Or if, I can't accept, dinner from you, but you could send cookies to the office to share your appreciation. It's also important to consider how this gift may affect your ability to care for the patient in a fair and objective manner. If people start giving you more luxury gifts, are you more prone to answer their calls first? Are you more likely to do certain things differently than you would for other patients? And also, if you get gifts from one patient and not another, does that change how you may treat or feel about the patients who don't give you gifts to show their appreciation? You may ask, if I accept this gift, will I be obligated to spend more time and effort on this patient than I would otherwise? It's also really important to consider how much of an impact monetarily or within the relationship the gift has on the patient. Next slide, please. Let's go the other way. So this may not be as common, but certainly something that comes up: financial assistance from the clinician to the patient. So let's picture a couple of scenarios. And again, this is a continuum, and there are extremes on this spectrum as well. So again, I'm a pediatrician, so I'm going to use a lot of pediatric examples. The mother comes in with the pediatric patient who's crying, really wants something from the vending machine. The mother just doesn't have change for the vending machine. You may consider giving the money to the mother, could just give $1 so that they can buy their chips. Or maybe you go to the vending machine yourself and just buy the chips because you know this doesn't mean much to you, the dollar, but it could mean a lot for the child, relax the child and get them ready for the visit. Beyond that, you may consider another example where a patient comes in and tells you they haven't been taking the medicine that you prescribed them. And you ask why. And they said, well, I couldn't afford the $20 copay for the medication. Might you consider giving them the money or calling the pharmacy and paying that copay? And think about that kind of scenario and think about, would it change if the patient knew that you did this versus if you did this anonymously and somehow you let them know that, you know, oh, we just were able to get the chips from the vending machine and that you didn't put the money out, or that the pharmacy waived the copay so that they didn't know it came from you. Next slide, please. So again, institutional and community norms really will determine these reactions. On one side, the gesture is a key to a robust provider-patient relationships, and it allows them to reach out to the patient with compassion and sharing. This is what we do on a daily basis. This is why we're all in the medical field, because we care about people and we want to treat them and want to get them better. But on the other side, there is a burden on the provider to treat more than just the medical situation. And you can't overcome poverty with such small gestures. The question then becomes, you know, when does it end and what are future expectations on both sides? Do you feel the need to continue this generosity? Do you resent the patient if they still don't take their medications that you paid for? Or if you notice that they may use money for what you may consider things that are not necessities or luxuries, and yet you're paying the copay for their medication that they may or may not be taking. So these are all important issues that may come up. Next slide, please. Okay, so social invitations from patients. It may seem somewhat black or white, but there really is a lot of gray area in this scenario as well. There are a lot of possibilities and extremes. So let's say you take care of a patient and she happens to be a dancer and she injured her foot and you take care of her. And now she's able to go back and do a show or a recital. And she says to you, oh my goodness, thank you so much for your help. I really want you to be at my show. Do you attend? You know, another example, you may be taking care of a chronically ill patient, maybe somebody with a chronically ill from birth, or maybe a long-term cancer patient, and they're better, or they're doing well, or they're stable, and they have a birthday party, and the family says, you're so involved in our care, we really want you to come and celebrate with us. We can move along the spectrum of this to maybe dinner invites. You know, a patient may ask you to dinner or for coffee. Some of these invitations may be clearly crossing boundaries between the professional relationship, but others may be a little bit more in a gray area. Your patient may notice that that you like a certain cup of coffee, or run into you at a certain coffee place and say, oh, we should meet up to grab a cup of coffee one day at this place. We both seem to like it. So there are a lot of questions that can come up in these kinds of scenarios. Next slide. So professional interactions really have social components that satisfy our need for human connection. We want to communicate with others. We don't want to sit in a box and not see patients. This is what we do on a day-to-day basis. And the decision to socialize really requires a clarification of limits and the nature of this dual relationship. We need to really be clear with the limits of and the nature of any relationship or any interactions outside of the office. And what it comes down to is really social relationships are complex, but it's important to be clear and set those limits up front. Next slide. Okay, so clinician-patient touch. So touch can come from the patient or it can come from the clinician. So you may be inclined to put a hand on a patient's shoulder or a family member's shoulder or hand to comfort them, or give them a hug if there's a happy situation or even some sad news. Or maybe, you know, every time you see this one cute little 4-year-old patient who loves to hug, you give them a big hug. You know, these are all scenarios that we may encounter on a daily basis. There are definitely some touches that would be clearly inappropriate for the doctor-patient relationship, but many instances of personal touch really may be subject to both personal and cultural values and the situation itself. So it's really not a one size fits all. What I may be comfortable with may not be the same as what another clinician in my office may be comfortable with. And that's the same with patients as well. Next slide, please. So the best way to approach this is you can limit your physical touch to the physical examination and comforting gestures. I think those are the most clear in areas where it's permissible. And if a patient initiates touch, you should respond graciously. So what does that mean? So it doesn't necessarily mean, if you're not a hugger, it doesn't mean hug the person back just so that you don't have to encounter the scenario. You may not be a hugger. So if the person clearly is reaching out for a hug or something more, you may let them know that your preference in general or your comforts are not to hug, patients, and that you're not comfortable with that, and you'd prefer a handshake, and that you really appreciate that they're showing their appreciation. Next. The other thing is you want to set clear limits. So that's the recurring theme here, is that you always want to set clear limits when you're concerned about the meaning of a physical gesture, and only initiate physical contact intended to meet a presumed therapeutic need of the patient. So that's a really important part here. When we're trying to comfort a patient, our goal with any touch on the shoulder or hand is really to meet the therapeutic need of the patient. And your physical exam is obviously meant to obtain the data you need to appropriately treat the patient. Next slide. Okay. Boundaries in the digital age. So there are so many new issues that have emerged and continue to emerge so quickly on an ongoing basis with the digital age and social media. For example, for anyone in my generation who's still using Facebook, should you be Facebook friends with patients? Does it matter if they're current patients or prior patient? These are things that come up very often. You may also be a part of different groups online. If you see a post, should you comment about the healthcare and medical care of a patient? And does it matter if it's your patient and you're responding on social media versus somebody else's patient that you've never met and you're commenting on these things? Let's also not forget patients reaching out to you on social media or texting or calling in off hours. Dr. Villamuri mentioned, a scenario where you may give your phone number out and say, okay, in an emergency situation, please call me. But oftentimes patients may not utilize the number just in the scenario where you've approved it. So they may text you in the middle of the night with a question. Oh, I'm so sorry, I just want to know this. Or consistently text or call utilizing off hours. And if a patient emails you, that's another thing. Do they expect an immediate answer? So if they email you at 11 o'clock at night, something that should be an emergency call to the service, are they expecting an answer? Are they emailing throughout the day or throughout the weekend? How are these expectations set? So all of these things need to be addressed whenever you're providing any information to patients in terms of your contact. So the boundaries in the digital age, there are a lot of nuances in the digital age and social media. And again, different providers have different practices and comforts, and you have to find what's appropriate for you. But it's important to let patients know when and how you'll be available and set these limits and stick to them. It's also important to be prudent when considering the blurred lines on social media. So you may be crossing from professional interactions to social interactions. You may have one page where it's your personal page, and you may have pictures of your family, things that you do. And if you commingle patients with that same private life, you may not have the boundaries that you anticipated. Next slide, please. Okay, and lastly, I wanted to talk about treating VIPs, friends, and family members. And there are really two different concepts here. I think the VIPs and the friends and family members, although there is some overlap there. So the question is, when you have a VIP, do you change your management because it's a VIP? And you have to also be very vigilant with the confidentiality, similar to any other patient that walks through the door. Although you may be bursting to tell somebody that, Tom Cruise is on your ward and you're caring for them, you really have to have that same sense of confidentiality. And with family members, it's a similar program. We could all think of a time when a family member calls you up and said, hey, I know we haven't spoken in a while, or a friend, or even if they have spoken to you recently, can I ask you a question about X, Y, and Z? I'm not feeling well, this is happening, or my daughter's not feeling well, this is happening. And it becomes a little bit difficult because you may not know the full history. There may be some sensitive information that either you're not provided, or now that you know, you have to be careful of with the rest of the family. You're not examining the patient. And they may call also at all hours of the night. So if you answer that one question, how does it end? When do you decide, we really need to limit this, and you need to see your own professional, your own provider to care for your medical illness or your problems, because there is a lot of overlap here between being your family member and being your provider, which you are not. Next slide, please. Okay, so with family members, the AMA has deemed it inappropriate to really treat family members, and there are a lot of reasons for this. We may not be able to really be objective when it's our own family, and we may also not have all the information, again, because we're not there as their provider taking a full history, or maybe there's some sensitive information that the family or friends want to leave out. So the decisions may be compromised by our feelings or by the information. And there are also confidentiality issues. Again, if you have sensitive information from, your cousin or your cousin's child, and the mother wants to know about it, it's not something that you can disclose, similar to if the patient was in your office. And VIPs. So we have a lot of ethical challenges with VIPs. Again, it may be difficult to get relevant medical history. There may be some sensitive information there. And there's always the issues of confidentiality. Would you order an additional test or additional testing that you find unnecessary because, let's say, President Biden is on your ward and he asked for more testing, or because you're worried that you might miss something, and so you order an extreme battery of tests? Are you giving more time to this patient as compared to others because they're either a VIP or family? And are you ordering more tests for fear of missing something, or because they're requesting it? The ultimate challenge there is to treat these patients the same as every other patient. And if it's family, they may not be your patient, and you should defer to their own providers. Next slide. So just a couple of conclusion points, and then we're happy to open up discussion. So caring between clinicians and patients and families can best thrive with mutually understood boundaries. We have to make those limitations clear and stick with them. And if you're unsure, again, a lot of these scenarios may not be black or white. There's a big gray zone. And most scenarios really aren't at the extreme. If you're unsure of the most effective response in a moment, it is safer to err on the side of firmer boundaries, and then to pull back rather than to go the other way. And I thank you for your time.
Oh, thank you so much. That was fantastic. What a lot of great information and great guidelines. We have a very interesting comment in the Q&A, and I know that we're over time, but if you want to stick around, I'd like to get to that. If you'd like more information about a 30day.com trial, no credit card is required, please contact me. And I want to thank our presenters and everyone who has joined us today. The recording and the PowerPoint will be on the .com YouTube channel shortly, and please contact me again if you'd like a trial subscription. So the comment is, and I will unmute everybody, but I'm interested in asking the two of you about this, that I find not calling me by my title, doctor, and addressing me by my first name, that boundaries are being crossed. So what do the two of you think about that? Do you think that not being called by doctor and instead by first name, that's crossing a boundary?
So I can give my opinion. I think one of the principles that I talked about was setting the professional relationships. And so it depends on what the setting is and where you are. And if you are in a professional setting, I think having that being called as a doctor, I think establishes the relationship of what you are. And it may come across as being, snooty, or, oh, I'm the doctor and you need to call me, but it's not necessarily. It is setting the boundary so that further interactions are based on that professional relationship. And sometimes not only is it not setting the relationship and boundary, but calling your provider by their first name is not showing the respect or trust with the provider, and kind of negates what they're saying. So it depends. I mean, if it's something you're comfortable with, and that's, again, you should examine if it's something that you would do with all patients and be comfortable with all patients, then you could accept it. But if not, then it should be the same for all patients.
And that differs by country. So for example, in Iceland, it's doctor first name.
Yeah.
Sort of combining the two.
Absolutely. Yeah.
And that's also true oftentimes in pediatrics, or if you have a very long last name like mine, we may have the patient's calls, oh, Dr. Eleni is coming to see you, but it still sets that standard that I am the doctor. And it has nothing to do with whether they can pronounce my name or not, but it's that level of respect, knowing we're here in this relationship, in this professional relationship together. We are not friends sitting down and having a cup of coffee. But again, this is how I would approach it and how I like it. I wouldn't expect any of my patients to just call me by my first name. I don't think it would be acceptable going forward. And again, I think things like that can also come up when you become, let's say, when you're dealing with people on social media where your name is there and you may not be Dr. So-and-so, they may reach out and say, okay, Eleni, what do you think about this? And we're taking a step back there. And I think we're not able to maintain that professional relationship. Again, nothing is 100%, but I do agree with you that if we've all earned the title of doctor, we're there in that professional setting to be offering medical advice. And I think you should be referred to as a doctor. I will say, I think it's interesting. I think it also comes up in other scenarios, like, if you might be going to a school function for your child, if you might be doing different things outside in the community where you're not acting as a doctor, people may have different opinions of that. For me, I don't expect anybody to call me doctor unless I'm in the doctor role at that particular time, but other people may feel, hey, I earned this title, and rightfully so. I want everybody to call me doctor wherever I am. So there's a little bit of little differing opinion, I think, there as well.
And we have another comment in the chat that this is fantastic. Thank you. Important, though, to show respect to the patient as well by asking how they would like to be addressed.
That brings up, and that's what I was going to say, that there's a lot of other issues involved in that. And sometimes you find gender biases in that, whereas, if the patient is calling you by your first name, but your male professional colleague as doctor, and that could be a gender bias there as well. So being aware of all those other biases, not only the boundaries of the professional relationship, also plays a role. Asking the patient how you would like to be addressed is respectful for the range of gender identities out there.
Okay, thank you so much, everybody, for attending this, and thank you to both of you. This has been absolutely great. Thank you, everyone, and stay tuned for our next webinar.
Thank you.
Thank you.